Good evening, everybody, and welcome to the ESSO webinar, a webinar of the European Society of Surgical Oncology entitled Trial Updates in Esophagogastric Cancer Management. As you see, please can you tell, okay, switch on a presentation mode. In modality, the mission of ESSO is cure cancer together. Please go on, and we will briefly review why join ESSO, because we will have a reduced rate for ESSO Congress and all ESSO educational activities. You will have a discount on HSEO subscription. It's a platform to increase your network, also for enjoying educational grants, a number of research opportunity with the ESSO Research Academy, and obviously a global network of surgical oncologists all over the world. Next one. As we said, there is a discounted fee for the European Journal of Surgical Oncology, which is the flagship journal of the society. It's official journal both for ESSO and BASO, the British Association of Surgical Oncologists, where you can read and for discounted fee and publish for discounted fee. Go on, please. ESSO is also the official organization for the European Society of Board of Surgical Qualification and Examination in Surgical Oncology. Each year we organize the examination, which is valid at the European level, usually with a written exam, and then the oral exam takes place just the day before or just the day after the annual conferences. As part of our activities, we organize several ESSO courses. For example, for upper GI, one of the most prominent is the one who is happening in Utrecht. The next one on esophagogastric and gastrectomy, focusing on minimizing treatment. The next one is planned in October 2026. So please join. As for example, another opportunity for pancreatic cancer is this ESSO advanced course on pancreatic cancer happening in October 2026 in Gothenburg, Sweden. Next one, please. And I hope that I will see you all together in Madrid for the annual conference of ESSO. The theme of this conference will be Surgical Oncology Without Borders, Innovation and Challenges Worldwide. So the preliminary program could be found already in the official Congress webpage. So I really invite you to join the conference and meet you all there. Thank you. John, please.
Thank you, Laura. So welcome all guys to this webinar in upper GI cancer. This webinar will be about the trial updates in esophagogastric cancer management. Today we will have two speakers. The first one is a medical oncologist from the Champalimau Foundation in Portugal. The second one is a surgeon from the University of Oxford in the UK. I think that Sheraz is ready for his presentation. So Sheraz, welcome to this activity, this ESSO webinar. Thank you very much for being here, and I think we all will enjoy your presentation. Sheraz, the floor is yours.
Brilliant. Thank you very much, John. I'm just going to try and share my slides. There, brilliant. Okay, so hopefully you can all see that. First of all, I'd really like to thank John and Laura for the opportunity and the privilege to present today. I'm going to talk to you about esophagogastric trials, and with an emphasis on surgery and where we are and potentially where we really should be going in the future. So my name is Sheraz Marker. I'm Professor of Upper GI Surgery at the University of Oxford and Director of our Surgical Interventional Trials Unit here in Oxford. I'm also a practicing consultant esophageal and gastric cancer surgeon here at the hospital in Oxford. These are my disclosures, none of which are relevant to this talk. So there are four main questions, I think, in surgical trials that I hope to address during this talk. The first is really around surgical access, and I'll talk about minimally invasive surgery, where we started, and also robotics, where we're going. Organ preservation as an area of research, I would say, at the moment in surgical trials, and potentially avoiding surgery. Extending the indications of surgery, and I'll talk about my interest in oligometastatic resectional surgery as well. And also, how do we make surgical trials better in the future? Okay, so first of all, let's start by talking about access. So we all know a landmark trial published by the Dutch, which was the TIME trial, which is a randomized controlled trial of minimally invasive versus open esophagectomy. This was totally minimally invasive through a laparoscopic abdomen and a thoracoscopic chest versus open chest and open abdomen with an Ivor-Lewis approach. And it showed essentially a massive reduction in pulmonary complications within the hospital by about threefold, which led to a huge uptake of minimally invasive esophagectomy across the globe, really. It's important to look at the N numbers, I think, with these patients. We had 59 and 56 in these patients. So I wouldn't describe this as a phase 3 randomized trial, but it's important evidence nevertheless. At the same time as the Dutch were doing their trial, I worked with Christophe in France, Christophe Mariette, and we undertook the Miro trial, which was a trial of hybrid esophagectomy. So it's a laparoscopic abdomen and open chest versus a open abdomen and open chest. We had around 100 patients in each arm. We essentially showed, again, a reduction in major complications by twofold, going from 64% in the open group to 36% in the hybrid group. And interestingly, in this trial, we also suggested that there may be an improvement in survival associated with a hybrid approach, primarily mediated through complications. It was very subtle, if it was present at all, but it was marginally present, at least within the trial. The Dutch have also gone on and done a trial of laparoscopic versus open gastrectomy called the Logica trial. This was a multi-center randomized control trial led out of Utrecht by Richard van Hilgersberger, a former mentor of mine. Essentially, what is important to note within this trial is that a laparoscopic gastrectomy compared to an open approach had no benefit in terms of length of hospital stay, complications, or oncological outcome. However, what was interesting is when I looked at the Dutch data during the timeline before and after the trial, if you look at the solid grey box, that represents the timeline of the trial from 2015 to 2000 and halfway through 2018. But essentially what you see is a massive uptake with the solid black line in terms of minimally invasive gastrectomy. However, what was interesting is the solid blue line, which essentially shows the complication rate for minimally invasive gastrectomy, which essentially dips after the trial. So perhaps it could be argued that in actual fact they were going through their learning curve during the trial. In actual fact, they saw the benefits to a minimally invasive approach after the trial. So this is cohort data, but it was interesting because it was in actual fact in the same country where the trial was conducted. Now, when we start to think about robotics, this is a trial again led by Utrecht, which was looking at robotic esophagectomy versus an open esophagectomy. So it's 54 patients in the robotic arm versus 55 patients in the open arm. It's an industry-sponsored trial, the Robot 1 trial. And essentially what they showed was in their primary endpoint was a reduction in major complications, going from 80% in the open group to around 60% in the robotic group. What I think is also important in this trial is to place it in the context of your own practice. So this trial had a high leak rate with a leak rate of 20% in the open group and 22% in the robotic group, requiring surgical intervention. This is type 3 leaks we're talking about here, which is significant and important to consider. What was interesting in the context of the trial comparing robotic versus open, that there was an improvement in patient pain scores whilst during their hospital stay, which was consistent across the timeline. And there was no difference in overall survival or disease-free survival within the context of the Robot 1 trial. Again, this is comparing robotic with open esophagectomy. When we tried to summate the evidence of robotic esophagectomy, what we can say is that there does appear to be, from the Robot trial, a reduction in perioperative morbidity, particularly fewer pulmonary and cardiac events, less post-operative pain, faster functional recovery, and comparable oncological outcomes. Now, when we start to look at robotic versus a traditional minimally invasive approach, so thoracoscopic chest, laparoscopic abdomen, the best data really comes from the REVATE trial, which is a Far Eastern trial, which suggests that there is an improvement in lymphadenectomy, particularly dissection around the left recurrent laryngeal nerve, completion of dissection around this area, with an improvement in overall lymph node harvest is also seen. What we can say when we summate the evidence in terms of long-term overall survival, the REVATE trial has just been published in terms of their long-term survival, and it did suggest a slight improvement in overall survival compared to minimally invasive approach. In terms of the Western data, the ROBOT 2 trial has just been completed and led by Peter Grimminger in Mainz. It has reported in its abstract form, and it does suggest that there is an improvement in lymph node harvest associated with a robotic approach compared to a minimally invasive approach. However, that data has not been published in full format yet. Now, when we look at the data of robotic versus laparoscopic or robotic versus open gastrectomy, what we can see is, again, it parallels the data seen in esophagectomy, with a robotic approach associated with improvement in short-term outcomes, improvement in perioperative recovery in terms of less blood loss, and improvement in terms of length of hospital stay, and higher lymph node yield in terms of retrieval. I think the largest scale trial is the trial, the JCOG 1907, which is awaiting to be reported, which is the largest scale trial conducted across 46 institutions in Japan, powered adequately with over 1,040 patients being recruited. I believe it will be the definitive trial in the field, and we're awaiting the results of this to really see whether or not this reduces intra-abdominal complications definitively or not, which I think will be important for the field. So to summarize the data on minimally invasive or surgical access, what I would say is that a minimally invasive or robotic approach compared to an open approach appears to improve short-term recovery and have equivalent long-term survival. It's important to note, particularly in a Western population, that there is no evidence that robotics is superior to minimally invasive for a tangible patient outcome. That's both in terms of short-term and long-term outcomes. All we have is there may be an improvement in lymph node yield, but that is again driven by superior mediastinal dissection, which is not routinely performed in the West. So then I want to move on to talk to you about organ preservation strategies. And I think what this really comes down to is trying to avoid the quality of life issues that we see with radical surgery, and particularly esophagectomy. This was data from the laser study, which I published a few years ago, whereby we showed that really around 30% of patients experience significant effects upon their energy levels, along with proximal reflux up to 3 years after resection. So the Dutch undertook the SANO trial. This is a trial whereby they randomized in total 274 patients, that's out of over 1,000 patients, to either having surgery or surveillance if they had a complete response to chemoradiotherapy. It was powered on non-inferiority for 2-year overall survival and disease-free survival. What the headlines from the trial was that post-operative morbidity and mortality was equal in those patients who had upfront surgery versus those who had salvage surgery if they recurred in the surveillance group. And they stated there was a better health-related quality of life in the surveillance group. Now, I am very critical of this trial, which I will talk about in a second. So problems I have with SANO is that it's a mixed histological subtype trial, including adenocarcinoma and squamous cell carcinoma. We need to stop doing this in esophageal cancer trials. These are not biologically similar cancers. They're very different. They behave differently in response to chemoradiotherapy. Also, complete response is very different, means different things in these histological subtypes, and they should no longer be grouped together in trials, I believe. The survival curves actually cross at 24 months, which is interesting, especially for adenocarcinoma. And there was no survival data provided in actual fact based upon those patients who had a salvage resection versus those who had upfront surgery. And we know historically there is some data in cohort studies which suggest that if you wait longer in your salvage group, the survival outcomes is poorer. So that's really important data that we await. I know it's presented in abstract form at ESSO, but we're still waiting for that data in full publication. There was a difference in follow-up between the groups, and this is a methodological issue with the step wedge design, and it's something that really should be important because you have a higher censoring rate in a 2-year follow-up study, particularly in your surveillance group, which is actually really important when we start to think about long-term survival in this group. Also, what we saw in pre-SANO was that there's a really issue that we have with detecting a complete response. The long and short of it is that we actually cannot reliably detect a complete response after chemoradiotherapy in this cohort. ctDNA may help us in a systemic component of disease, but it's actually something that needs to be validated in more robust fashions. So the other things that I think are important is the surgical outcomes in SANO weren't great, in my opinion. The anastomotic leak rate was between 22 and 27%, which most of us would consider to be high. There was a contamination effect in terms of 35% of patients from the pre-SANO trial were included in the trans-SANO trial, which methodologically makes no sense at all. The non-inferiority margin they selected to be 15% at 5 years, not at 2 years, which is what they've reported on. So in actual fact, when you asked patients, they said, yes, we would happily accept a non-inferiority margin of 15%, but this was at 5 years, not at 2 years as reported. Also, the health-related quality of life was equivalent at 12 months. When in actual fact, when they said it was better in terms of surveillance, what they meant was that it was better at 6 months, when we all know that it takes at least 6 to 12 months for patients to recover from esophagectomy. So I don't think this is a very fair comparison, in my opinion. The other thing that I want to talk about is oligometastatic disease. So this is a particular passion of mine and an area of interest that I practice in Oxford. So this is going to become increasingly important. So we've just completed recruitment for the Sarong trial, which is a randomized trial of intensive surveillance versus standard clinical follow-up in the UK. We are powered to 952 patients. And I think what was interesting is that this is the fastest recruiting trial conducted in esophageal and gastric cancer in the UK, which is exciting for us because it shows that we're able to recruit to this trial in good levels. But what will be interesting is that we will diagnose a lot of patients, I believe, with single site recurrence pretty quickly in this trial. So it'll be interesting to see how they're treated moving forward. We also have an international trial, which Laura is part of, called Sarong 2, led by Jesse Elliott from Dublin and Scandinavia, which we've got some grant funding for, to really look at exactly the same issue in a European cohort of patients, which I think is a really interesting idea to see whether or not we can duplicate the results in international cohort versus that in a UK cohort. When we start to think about synchronous disease, we can't ignore the Renaissance trial, which has been presented and hopefully will be published quite shortly. So this was a trial in patients who presented with limited metastatic disease. They had 4 cycles of FLOT. So they presented at diagnosis with limited metastatic disease. They had 4 cycles of FLOT, and then they were randomized to either having surgery or a further 4 cycles of FLOT, or just carrying on with 4 to 8 cycles of FLOT and then follow-up scans. So it's really looking at the value of aggressive surgery or treatment of oligometastatic disease. They were a mixed trial in terms of site of metastasis. What I think is important is that peritoneal metastasis was included in this trial, which is an important, I think, potentially exclusion factor that we can think about in the future. So this trial essentially shows no improvement in overall survival to treatment of patients with limited metastatic disease, which is, I think, an important outcome in many ways. It's a thing for us to start to think and take stock as to potentially why, and really start to think about how we can potentially improve this in the future. When we break this down by subgroup, what you can potentially see is that there maybe was an improvement in the retroperitoneal lymph node group in terms of overall survival associated with surgery. The liver metastasis group really had no improvement in overall survival at all. And potentially in the peritoneal metastasis group, surgery was actually harmful in actual fact in this group. So potentially that's a group that we really have to think about quite carefully as to whether or not we offer aggressive surgery or not. I think the take-homes from Renaissance, I put lots of pictures of my children in, partly because my son is always very excited and my daughter is maybe a little bit more skeptical. So I think when we start to think about Renaissance, the take-home messages is that there was heterogeneous inclusion criteria based upon the site of metastasis. I think we would class the inclusion criteria for the trial as quite broad. They allowed up to 5 liver metastases, which is quite a lot, in all honesty. There was also a high rate of reoperation. For example, there was more than 20% patients required a reoperation in the retroperitoneal lymph node group. At the time, it's important to take the fact that there was poor systemic options. Immunotherapy was not a thing at the time the trial was undertaken. So that's important when we start to think about this in the future. And there was potentially a prognostic signal in the retroperitoneal lymph node group, but it's something that needs to be investigated, I think, a little bit further. Richard van Hilgersberger has led the OMEC definition, which is trying to create a uniform definition, at least within Europe, as to how we classify oligometastatic disease and potentially look at treatment strategies for oligometastatic disease. So an international and European consensus was undertaken, and this is what we have from the OMEC group, which is a consensus based upon one organ with up to 3 metastases or one extra regional lymph node group, lymph node metastasis, and you have the consensus based upon the organ burden there. However, what's important is that this is just a feeling. This is just a definition based upon what people feel at the time. And they've looked at retrospective cohort data to see whether or not this is valid, and it appears to be valid in retrospective cohort data. But this has never, ever been tested in a randomized controlled trial. So we don't know whether or not aggressive treatment of oligometastatic disease makes a difference in this group. And this is what we propose to do with the Relogo trial, which is a randomized controlled trial, which we've just put through a grant application for in the UK to conduct also as with European sites, looking at whether or not we can randomize patients who have stable disease after 6 months of optimal systemic therapy, that includes immunotherapy, and ctDNA stability as well, randomizing them to having either resection of the primary and local regional treatment of the metastases, or carrying on with best systemic therapy. I think what's important is that when you ask patients what they want, is yes, they want to survive, but they want to survive with a good quality of life. So this trial is paired, has a co-primary endpoint of both survival and health-related quality of life. Also, we will collect functional recovery of these patients. And as I said, it's including 15 UK centres and 8 European centres. So it's a potentially large-scale randomised control trial, really testing whether or not this OMEC definition holds weight in terms of aggressive treatment. And finally, I want to really touch on whether or not surgical randomized control trials have external validity. And I often think it's a bit like taking a picture of your kids. You take a really nice picture of them and they seem very happy and life is great, but then the reality can be quite different when you get them on a plane. And really, this is the classic example of this. This is the Dutch trial, a paper that we published a few years ago now in JCO. We looked at essentially minimally invasive esophagectomy in Holland. We showed that essentially in the Dutch trial time, there was a massive reduction with pulmonary complications associated with the minimally invasive approach. However, when that technique was introduced nationally within Holland, there was an increase in pulmonary complications associated with the minimally invasive approach. So that trial has no external validity in the same country where the trial was conducted. So the question is what are we doing here? We're doing these trials, but in reality, they have no external validity when the technique isn't applied nationally. And what's important is when we look at surgical trials, this is a slide that I borrowed from George Hanna, my mentor. What is important is that none of the surgical trials, randomized controlled trials, where the intervention was a surgical intervention, have ever shown an improvement in overall survival. Now, we're in the business of trying to change survival here for our patients, and yet we've never, ever conducted a trial that has shown an improvement in long-term survival associated with a surgical intervention. And the question is why? And George and I both agree on this, is that we believe that it's because there's a variability in surgical performance between centres and between surgeons, which actually overshadows or overpowers the intervention being examined within the trial. So rather, when you do a randomized controlled trial, you assume that 100% of your surgeons in arm A are going to perform the operation exactly as it should be performed when you compare it to arm B. But that, in reality, is not representative of the real world, and we know this. So the question is in our mind, is how do you meaningfully integrate surgical quality assurance into the life cycle of a trial? So surgical quality assurance is a process whereby we essentially standardize the technique, we ensure that surgeons are of a good quality before they enter the trial, and then we monitor the performance of the trial. So we wrote this editorial for you last year, actually. We published in Annals of Surgery. And essentially what we believe is that we could essentially integrate this within the life cycle of a trial. So in your pre-trial phase, when you're building up your trial, you standardize the technique, you credential the surgeons before they enter the trial. So then what you have is you have a good body of surgeons who can perform the technique to a standard that you think is acceptable. Okay. Then in any trial, there is always an internal pilot. And what we always do with that is that we use that to see whether or not we can recruit patients to the trial. But what George and I think we should be doing is that we should be looking at whether or not surgeons are performing the technique to a good level. And what you will understand is that you'll understand that there's a variability in performance. But what is that variability? It may be around, something ranging between 60 and 80% or something like that. And then you redo your sample size based upon that adherence to the protocol. So then you end up with a larger sample size, but what you know is that that's going to be more reflective of real world practice when you implement your technique after your trial. So therefore you end up with a more representative trial of what it is actually for surgeons undertaking this technique in the real world. And then finally, I'll talk about the integration of surgical quality assurance within the IDEAL framework. So I'm the methodology lead now for the IDEAL framework, which is really a framework for how we should conduct clinical trials within surgery. And what we've developed, and this is a consensus process, which is currently under review for publication, but we've looked at essentially every phase of the IDEAL framework and how that parallels with the phases of surgical quality assurance. So if you look at phase 0 to phase 2B, you're standardizing the technique. So you're looking at all the potential variations in the surgical technique and you're standardizing them. From stage 2 to stage 3, you credential your surgeons, and then going from stage 2B to stage 4, you actually monitor the performance during the trial. And it's an iterative feedback to constantly improve the quality of surgery. And likewise, we've gone through this process whereby we look at exactly all the technical steps that can be modified and how they should be standardized, and creating an operative manual as you go through every stage of the IDEAL framework in any surgical interventional trial. And then finally, we look at how we can use video recording and artificial intelligence to improve that process as we go through the phases of a randomized development of a randomized control trial, going from the pre-trial phase to the ultimate long-term study. So to conclude, I think the future of surgical trials is exciting. I think we're going to move towards doing more advanced resections for patients who potentially would have presented with unresectable disease to start off with. I think robotic surgery, including the SP platform, which I haven't talked about because there's really no data or randomized data around it, is an exciting area for future research. Also, potentially organ preservation. I mean, whilst I am skeptical of the SANO trial, I think potentially in MSI positive patients using immunotherapy, it's definitely an area of research to consider. However, what can't be ignored is the quality of surgery within and outside of randomized controlled trials is absolutely crucial. So we have to really focus upon this if we're going to have interventional surgical trials in the future. So with that, I'll stop, and I'm very happy to take any questions.
Thank you, Shiraz. Thank you for this wonderful presentation. I think we will have the final discussion with question and answer at the end, even though we just started receiving it. So John, please, your task is to introduce the following speaker. Me, Carlos, can you hear me?
Yes.
Okay, super. So a lot of updates. I perfectly agree with your presentation that we have a little bit of confusion about the different type of tumors that were mixed up in different trials, starting with esophagogastric junction and adenocarcinoma, squamous cell carcinoma. These create a little bit of a mix, but that are coming with new and encouraging. In particular, I think the Matterhorn trial is completely game changer. Will enable to see us with more and more responses, and possibly, I don't know if we are going to open in the near future, as Shiraz was saying, and maybe a frontier for also organ preservation in gastric cancer. However, since we received a lot of questions and time is running up, I think we will read a few questions from the floor in order to let the speaker talk. I see Samuel Dinark asking Inomek. I think this was for Shiraz. You mentioned definitely giving trastuzumab. Is the HER2 status in gastric cancer heterogeneous and variable with therapy?
Yeah, so yeah, absolutely, it is heterogeneous. So we use HER2 in patients who express, obviously. So this would be one of the things that is actually very advantageous. I think the HER2 group is a really positive group in gastric cancer because they can carry on this therapy. So we've had some really good responses and operated on patients with in the oligometastatic setting. We've had spectacular responses to trastuzumab. So I think it's a group to definitely study. So going back to Carlos's original point, if a patient presents with oligometastatic disease, even if it's the potential of being non-resectable, we do all the markers up front, and then we get them onto the best systemic therapy. We do this for 6 months, and then we restage them, and we consider resection at that point.
So thank you. On another question, so if we are talking about, the molecular different types, a question for Carlos. What do you think we learned from the lesson that the matron gave us about PD-L1 expression and the possibility to give immunotherapy nevertheless? You think
Sorry,
maybe we
the possibility of giving immunotherapy?
the immunotherapy, regardless of the expression of the mark.
Yeah. So in the metastatic setting, there is no doubt that PD-L1 expression is usually correlated with response, and many of the decisions are depending, particularly in patients, as we are speaking of HER2. It's different when you have HER2 with PD-L1 expression or not. And even in squamous tumors, the degree of expression is also very important. And as you know, also there is a big heterogeneity in the tumors and also in the way it's measured. So you now have different ways of measuring the PD-L1 expression. So it's difficult to be absolute in the criteria, but in metastatic setting, very clear. When you go for perioperative setting, it's different because you usually you cannot get this kind of signal of the biomarker to take the decisions. And the Matterhorn is an example of this. 10% had PD-L1 negative when they looked at this. And the trial this is a planned analysis. The subgroup of PD-L1 and positive and negative was planned in the trial. But the number of patients with PD-L1 negative was very, very low. And then you had no power probably to evaluate such any significant difference when one of the groups is so small. And so you cannot be sure. And because you cannot be sure, you tend to give it even if the PD-L1 is negative.
Yeah, I mean, I suppose, Laura, one of the things to be clear about is that we haven't really got the breakdown of the CPS. It's not being presented. This is an industry-funded trial, so I think we have to be very clear on this as well. That there really is going to most likely be a subset within that group benefit maximally, but yet we don't know that because that data hasn't been disclosed.
Well, there is something with ASCO abstract,
I know.
but still, when you see the confidence interval, you see that it will take years to get enough patients to see a significant difference. So the NCCN guidelines, they use this in their comments, and they suggest that probably those patients with a PD-L1 negative are patients that probably have not such a significant benefit. So if you have, obviously, this may be important when you have an elderly patient that is frail, patient, and also the financial toxicity, because when you introduce immunotherapy, you are obviously the treatment. It does not duplicate the price. The price increases almost 10 times. So it's not easy to manage patients when you are doing flawed. And everybody, the patients usually think that doing immunotherapy is easy because the side effects are minor. It is true in many cases, but when you do have a significant side effect, this can compromise the life of the patient and to continuing of therapy. So you have to think twice.
Thank you so much. I have a final question for Shiraz. So in the light of the trial you're going to start in the oligometastatic setting, what do you think will be, the added value of giving a local control to an oligometastatic patient, and in which kind of oligometastatic setting would you suggest to have a local control, either with surgery, radiotherapy, or other complementary treatments?
So I think the critical thing here is for me is the systemic component of the disease. So it's an exclusively adenocarcinoma disease. So Carlos alluded to this, and I think this is really important, which is that if a patient is ctDNA positive after systemic therapy, whether that be in a neoadjuvant setting or in a palliative setting, they will recur almost certainly, no matter what you do. So this concept of counting metastasis and saying that this is stable is nonsensical in the current era. We have to be able to look at radiological, yes, stability or response, but ctDNA response as well as a component of the systemic component of the disease. In those patients, you have that level of response whereby ctDNA response and radiological response, I think they will benefit from having a curatively intended surgery, or actually, in fact, radiofrequency ablation of the Met, for example, or less invasive treatment. But they're your winners. If you go down the route of trying to treat everyone with just a radiological response, this will, in my opinion, will fail because you don't have an idea of the systemic component of the disease.
Wonderful. I'm back, guys. We have a couple of extra questions. I think we have time for 2 questions more. One is from Dr. Achurra. He says, what about cytology during surgery for gastroesophageal adenocarcinoma? If you have positive cytology before neoadjuvant treatment, do you consider this patient for surgery plus HIPEC or palliative chemo?
So actually neither, to be honest. What we do is, if they're cytology positive, but in the absence of macroscopic disease, we consider them to be M1. So it opens up the opportunity for best systemic therapy. Look, I think as surgeons, we need to get out of this attitude of saying, look, we're going to cure them like with surgery. This is definitely the way. You give them the best possible systemic therapy. And if calling them M1 opens up the opportunities for that, do that. Give them the best systemic therapy. Then restage them afterwards. And after that, we repeat the laparoscopy. If the laparoscopy is negative, we go on and operate them. And this is you're doing the best thing for the patient here, rather than trying to say, oh, in actual fact, I can cure them with an operation. That's irrelevant here. It's the systemic component of the disease will drive their survival here.
Can I just comment?
Yeah,
yes.
Absolutely.
Just to summarize, fit patients with very good responses to chemotherapy, they are winners and they deserve a more aggressive approach. And in an oligometastatic setting, this is key. So if they are fit enough to go to surgery, and if they have a major response, and you can measure the major response in many ways, most of the patients that do have a very significant response are good patients to invest. Sometimes you are in the middle, and the biology may be very, very important, ctDNA, tumor markers, whatever. And of course, you all know when the patient is not responding, and you should not go further, probably, because it's not going to be an happy ending, even if you try to remove all the disease you see. So,
yeah.
Good points. Good points of debate. And good answers also for the audience. You see that there's never a final answer for this but you should first of all do multidisciplinary management, and second, you need to individualize the treatment you offer to your patients. We're going to our final question then, from Fernando Perrota. He says, for patients with gastric and GG junction adenocarcinoma who have poor pathological response after perioperative flood, is there any data supporting durvalumab monotherapy as maintenance treatment in the adjuvant setting?
I showed. I know that it's a jungle of trials, but there is a nice trial called Signal that I put in there. That I think if you look through this, it's a nice design because it's exactly what we were commenting and particularly Shiraz was saying, and this explores this ctDNA after surgery, and if those patients that have negative ctDNA, the possibility of going only with durvalumab is nice. So this is already ongoing. So we may need more data. In practice, if you are in doubt and you have a more fragile patient that had toxicity with chemo backbone before, during the preoperative phase, you obviously also have to adjust and take a practical decision, even without trials. And sometimes we do only immunotherapy because we realize that the patient may get too much toxicity and may not even be able to get it. And you have to see that when you look at FLOT and Matterhorn, the percent of patients that could not complete all treatments is very significant. So you have even, and this was a selection, as you saw, of PS0 patients, very fit in a very controlled setting. So in real world, it's much more complicated. So practical decisions in de-escalating the treatment have to be made.
Yeah, I think the space plot study is a retrospective study, but is a nice study really around this, which just sort of makes the point that if a patient isn't responding to FLOT in the neoadjuvant setting, they're very unlikely to respond to it in the adjuvant setting. And like interestingly, if they have a complete response to FLOT in the neoadjuvant setting, there's no real benefit to giving it in the adjuvant setting, which is what I thought was interesting anyway, data. So,
True.
Thank you. Laura, do you have any other question or comment?
I think there was the final question in the chat about the approach to esophageal squamous cell carcinoma in the West. How do you approach it? How do you see it changing it?
So I think Magnus Nielsen has a very nice trial, NEEDS, which is a randomized controlled trial looking at neoadjuvant chemoradiotherapy plus surgery versus definitive chemoradiotherapy and surveillance with salvage for those who need it. It's a slow to recruit trial, but it is an important trial in the area. I do worry that in many ways that I think the definitive chemoradiotherapy group would benefit from having immunotherapy as well within the context of that trial potentially. I know Carlos alluded to the fact that there are many trials with a combination of chemotherapy and immunotherapy currently ongoing in the Far East, but less in the West. I personally think with squamous cell carcinoma, we will end up moving towards organ preservation, almost certainly. I think it's a matter of time because I think we don't see much of it compared to our Far Eastern colleagues. The morbidity from a 3-stage esophagectomy is high, without a doubt. And if you can do chemoradiotherapy and salvage those who require it, it's probably a better option, in all honesty. But yeah, Carlos probably can add to this.
I agree.
So thank you so much. I think that we can close the webinar here. If you have any other questions, you can write an email to the office and they will be happy to deliver your questions to the speakers. Thank you so much for taking part in this webinar. Thanks to Shiraz, and thanks Carlos, thanks John.
Thank you everyone.
Everybody.
Have a good evening.
Thank you all. Bye-bye.
Bye.
Thank you.
Bye. See you in Madrid.
Bye. See
Yeah.
you,
Thank you.
Manresa.
Bye-bye.
See you.
Bye.